All right, guys, let's get started. We're on page 1051, Med-Surg book. Going to do assessment of the urinary system, extremely important assessments. Also, this is a good time to bring in the fact that, let me just find this photo. Yes, this is it. Let's use this one. I want you guys to make sure that you have this book. This is a good book to actually help you whittle down the information during MP2. Okay, so just a reminder, you guys have to review the actual anatomy and physiology on your own. We're going to go over the diagnostics and assessment of the GU system. And you're going to, for GU, after we do fluid and electrolytes, you're going to learn about pyelonephritis, acute and chronic, interstitial cystitis, benign prostate hypertrophy, and prostate cancer, and chronic renal failure. So let's just make sure that you guys realize that this is chronic renal failure that we're going to actually do. You guys can read through the objectives for the GU system. Okay, we're on page 1051. We're looking at table 45-2, and we're just going to talk a little bit about what happens to us as we age. This is an important part of MP2 because we are studying chronic disease processes, and most of the time focuses on the elderly population. So as we age, the kidneys atrophy, and this means that they're less palpable. As we age, we have a decreased number of nephrons, and the blood vessels supplying the blood to the kidneys thicken. This means we have a decrease in creatinine clearance, but an increased BUN and serum creatinine level. We have a decrease in the function of the loop of Henle and the tubules, and this is important because this leads to an altered drug excretion, so we have to be very cautious in administering or prescribing drugs for the elderly population. Also leads to them experiencing nocturia. We then move down and talk about the ureter, the bladder, and the urethra. And so we have issues such as urinary retention. The urinary retention, the frequency, the urgency, and the nocturia are a result of decreased elasticity and muscle tone. The muscle tone can also lead to stress incontinence. Just so you know, incontinence is not considered a normal outcome of aging. So anytime that there is an incontinence issue, we do need to make sure that we investigate it. Also, the prostate for guys just naturally enlarges, and so this can lead to signs of BPH, which we're going to study at a later time, which leads to hesitancy, frequency, urgency, getting up at night, dribbling, etc. As we go through and talk to someone who has presented with a potential GU problem, we want to investigate their past medical history. We want to look to see, are there any diseases that are related to the renal or GU system? Do they have comorbidities that would increase the likelihood of having a renal or GU disease, such as hypertension or diabetes? We want to also ask them about, have they had any specific types of renal or GU cancers? Do they have a history, for instance, of kidney stones or BPH? We want to talk to them about their surgical history. Have they had any type of hospitalization or renal or GU problems that have required surgeries? When you guys look at 45-4, these just go through some of the different types of health pattern related questions that you could ask. So for instance, if we go down and we look at elimination, are you able to sit through a 2-hour meeting or a car ride? You know, do you ever pass urine when you do not intend to, such as like with coughing? Do you have or experience constipation? So you want to go through these things. When we look at the different ways that we can collect data for the assessment of the GU system, then we always look at the different types of methods, such as inspection, palpation, percussion, and auscultation. And so obviously, if we're going to inspect, then we want to make sure that we inspect the skin. The skin tells us a lot about the renal or GU system. Is there pallor or paleness? Is there excessive bruising? Look at the mouth. Is there any type of ammonia breath odor or inflammation of the mouth? Look at the extremities in the face. Is there swelling? Look at the abdomen. Is there any skin changes? Any contours? Look at their weight. Has it been increasing secondary to edema, or have they actually had weight loss or muscle wasting because of kidney failure? And just in general, their fatigue, any lethargy or diminished alertness. As far as palpation goes, yes, you can actually palpate the kidneys at the what we call the margin of the costovertebral angle. But this is done for an advanced practitioner, so we're not going to go over this. You can also percuss the kidneys, but once again, you would do this as an advanced practitioner. You would percuss for tenderness, especially in the flank area. So for instance, if someone was having issues with kidney stones, it's possible that you would note this on percussion of the kidneys. As far as auscultation, you can listen to the renal arteries, and you would listen for what we call a bruit. And I'm sure that in MP1 you guys learned that a bruit is an abnormal sound or a murmur. And yes, just going back to palpation, you can obviously palpate the bladder. It shouldn't be palpable unless it is full, and then it can be felt as a smooth, round, firm organ, and it would be sensitive to palpation because it's full. And going back a couple of pages, there is a chart that you guys need to know. This chart tells us about drugs that are nephrotoxic. And so we're looking here at the drugs that are nephrotoxic, and you need to know these drugs. This is something that will be tested frequently throughout MP2, and you'll notice, for instance, some of the ones that are common would be the sulfonamides, the cephalosporins, a lot of the antibiotics, Tagamet, methotrexate. This is really the non-steroidal, such as ibuprofen. But yes, you just need to go ahead and learn these now. On page 1056, it starts the diagnostics, but it also goes over a lot of different terms. And these terms at the top, you guys just have to memorize. These are terms that will often be used in the STEM portion of a question, and so be sure to review the terms on page 1056. And then at the below that, it starts to get into the diagnostics. The first one it talks about is a UA, urinalysis. Just know on page 1062 are the normal values for urinalysis. This is something that we'll practice a little bit in class, but you can start to read through what's considered normal in a UA and what is not considered normal in a UA. Also, below that is creatinine clearance. This is just a measurement of waste product or protein breakdown. Okay, so this is a 24-hour urine collection, guys. So what do? We have to discard the first void and then collect without missing all urine for a 24-hour period. And then we send it down to lab. We want to make sure that it is for 24 hours. And then if you skip to the next page, it talks about a urine culture. And a lot of times we would actually refer this as a clean catch or midstream. So read through this. You guys should have learned about the nursing responsibilities for a clean catch in MP1. So if we need a urine culture, there's a difference, for instance, between how men would prepare and women would prepare. So read through the nursing responsibilities. And then next, skipping down, a urine cytology. Let's just start to lay the groundwork now for cytology. Cytology is looking for abnormal cells. So if we're suspicious that there's a cancer, we're going to do a cytology. And so in this, we would be looking for a bladder cancer. Continuing with diagnostics on page 1057, the BUN, the blood urea nitrogen. This helps us to detect renal problems. Normal is 6 to 20. You need to know that number for the rest of the semester. We're just looking at how the kidneys are doing excreting urea. And so just be aware there's certain things that would cause this to be off. Fever, a bleed, a trauma, excessive muscle breakdown, steroid therapy. Also, we want to look at the creatinine. It is considered to be more reliable than the BUN, and it is an end product of muscle and protein metabolism. Again, you need to know the norm, 0.6 to 1.3. And uric acid is below that, and this is just primarily screening for someone who is having problems with purine metabolism and has what we call gout. You'll notice then it goes into the electrolytes. We've already studied the electrolytes. You guys should know these. You should know the normal values for the rest of the semester. These are a few more tests. You guys can read through these. The KUB, the CT MRI, you guys should have learned about an MP1, a cystogram, urethrogram, and then the actual urodynamic studies you guys can read on your own. These are pictures of a couple of other invasive procedures. The one is called IVP, which is intravenous pyelogram. And so this actually involves the injection of a contrast medium. And then we can look at the kidneys, the ureters, and the bladder, and you can see how they're highlighted. And so you can see the nursing responsibilities on page 1058. And so what we need to know is that sometimes the night before they might have them give themselves an enema, not necessarily. You want to always assess because there's dye involved for an iodine allergy. And you want to advise the patient anytime that there's an injection of a contrast material. A lot of times it makes them feel warm and flushed, but it's very transient. And you want to make sure that the kidneys are working so the kidneys can flush out the dye. A renal arteriogram is the picture that you see with the arrows, and this just visualizes the renal blood vessels and helps when we need to diagnose, for instance, if there's stenosis of the renal arteries. And so again, before the procedure, maybe an enema. Once again, contrast material, check for iodine sensitivity, make sure the kidneys are working. After the procedure, this actually is done through an artery, and so an artery is cannulated. It is inserted through the femoral artery and passed up into the aorta. So post-procedure, you have a site to watch. You have an arterial site to watch, usually the femoral artery. And so you want to make sure that you're watching that site and that it is not bleeding. A lot of times the patient is placed on bed rest and the affected leg is kept straight for a certain amount of time. You want to make sure that you are observing for a blood clot or any bleeding at the site or any type of infection. This is where we're going to learn about the 6 P's. The 6 P's. This is a neurovascular check. So we're going to check this extremity for a pulse, check the extremity for pain, paralysis, pulchothermia, paresthesia. The 6 P's. And it just means that there is adequate circulation to the leg. The last 2 procedures that we're going to talk about are cystoscopies and a renal biopsy. Let's talk about the cystoscopy. When we talk about a scope, the principle's the same. There's a scope. You can see a picture of a scope on page 1060. The scope then has a light source, a source through which you can pass biopsy forceps and irrigate. So with a cystoscopy, you're going through the meatus, you're looking at the urethra and popping into the bladder, and then you can visualize where the ureters go. And you, for this particular procedure, you're awake. It's not really that uncomfortable. It's often similar to like having a Foley catheter inserted, but most of the time the patient is MPO. Okay? They can take a look. They can look for possible kidney stones, any kind of inflammation of the bladder lining, any type of cyst or tumors, any type of narrowing, for instance, in the urethra. After the procedure, you just need to let the patient know that there could be some burning associated with urinating. There also could be some blood-tinged or pink urine, especially if they have taken any type of biopsies. And make sure that they understand the signs and symptoms of a bladder infection. I will post a YouTube video in the GU folder of a cystoscopy because it's interesting to see. The next would be a renal biopsy, and a renal biopsy would be done, for instance, if we were concerned that there was some type of kidney cancer, a kidney lesion, or we were unsure about the cause of possible kidney failure. And so this is going to be done in invasive radiology. Prior to going down, we need to make sure that the patient's clotting studies are within normal limits and that they have not been taking any kind of aspirin or Coumadin or anything that would thin their blood or alter their clotting time. They're going to take an ultrasound, locate the kidney, and then from there they're going to do the biopsy, guided by the ultrasound, as you can see in the picture. So post-operatively, we want to make sure that this patient has a pressure dressing on and that the patient lies on the affected side for 30 to 60 minutes, and that we're assessing them for any type of flank pain, hypotension, tachycardia, declining CBC, which would indicate bleeding, or anything that would indicate infection.